G'day, my name is Will, and today I'm going to be giving a presentation on the epidemiology of obstructive sleep apnea syndrome, or OSAS as I'll be referring to it. So OSAS as a disorder has only recently become a lot better recognised and understood, which has obviously shaped the availability of systematic reviews and randomised controlled trials on the interventions for it. So since correlation between the syndrome and obesity has already been established, the increasing prevalence of obesity is likely to directly influence its frequency. It's characterised by a blockage to the upper airways during sleep due to weak muscles leading to a pharyngeal collapse. Its symptoms include snoring, apnea episodes, so pauses in breathing, disruption in sleep, daytime tiredness, and resultant complications such as insomnia and depression. As CPAP, continuous positive airway pressure, is quite effective. It's generally recommended as a first-line treatment for mild to moderate OSAS. However, the concern with it over the years has been patients' adherence to its use, and hence consistent treatment of the OSAS has suffered. Factors like family, healthcare, and government issues all have a part to play on its disuse. The three sources I analysed take a look at physiotherapy exercise program intervention, a relatively new alternative to CPAP in OSAS treatment. So if we can improve the case for exercise intervention, we can reduce patient reliance on CPAP. Because the use of exercise as an OSAS intervention has only just started to become more popular recently, the amount of high-level evidence available for it is still fairly scarce. Using Cochrane, along with the database search engines including UC Library and Google Scholar, I searched for relevant articles within the past 5 years, so dating back to 2009. I made sure that between the control and intervention groups, the only thing that was tested or varied was the exercise program, so many sources combine this with a diet or a CPAP as part of the intervention, which I had to throw those sources away. Initially, I aimed to find a specific exercise technique across sources, but as there is no universal guidelines yet for OSAS exercise intervention, the studies differed slightly in their methods. So the keywords I used in my search were OSAS, exercise, effects, physiotherapy, and interventions. So sources analysed included one meta-analysis and two randomised controlled trials. The first source I studied was the effects of exercise training on sleep apnea, a meta-analysis. So the highest form of evidence I found was a level 1 on the NHMRC scale. However, as far as level 1 systematic reviews and meta-analyses go, its range of studies included was quite limited. So like I said earlier, it's probably influenced by the fact that there isn't a large amount of relevant RCTs currently available for the intervention. So from 498 articles it cited, it only consisted of 3 relevant RCTs and 2 single group studies for a total of 129 subjects. This small study group can potentially make the significance of the results attained somewhat questionable, but the statistical analysis they carried out was still thorough. The 3 authors were extremely stringent in their inclusion and exclusion criteria, so as you can see on the left there in that flow diagram, they only took control groups of stretching or no exercise, the complete randomisation of control and intervention groups, no CPAP usage during the course of the studies, no median or interquartile range data, and no reports with any ambiguous or missing data. Although not stated clearly in the source, it's assumed that because there were interventions of no exercise prescribed for some controls in the RCTs, that there wasn't complete blinding of subjects, let alone the therapists. Sensitivity analyses were also conducted to determine the contributions of the 5 studies used on the influence of the intervention for the key values determining OSAS severity. So that was the AHI, apnea hypopnea index, the body mass index, BMI, sleep efficiency, and VO2 peak. So I can just direct your attention to the improvements seen on the right there. So you can see that AHI events per hour is decreasing significantly, sleep efficiency and VO2 peak also going up quite significantly. So funnel plots and subsequent Begg and Mazumdar rank correlation tests were used to rule out any publication bias in the articles used. And given that as stated above, the intervention is a comparatively new one, the quality of evidence provided in this meta-analysis is still relatively strong and suitable to use when contemplating the use of exercise intervention in OSAS patients. The second source I analysed was the effects of oropharyngeal exercises on patients with moderate obstructive sleep apnea syndrome. So it was a level 2 piece of evidence. It was a randomised controlled trial on the NHMRC scale. Once again, it was a small but randomised sample size used. So it was only 31 subjects in the study. As compliance is an important part of a statistically relevant trial, the study only used data from individuals who passed at least 85% compliance to the exercise program and who returned for evaluation by a speech therapist at least once per week. However, it's one thing maintaining this high compliance over a 12-week period and while supervised. It's another thing to continue these exercises for an extended period and unsupervised. So blinding of the subjects, but not the therapists, also occurred, reducing the bias seen in this source. So the results they attained all appear pretty positive, with marked changes in not only AHI, so you can see the table there over the 3-month period, significant decreases in the events per hour, but also for the snoring frequency and intensity, as well as daytime sleepiness, or even the secondary outcomes. So the variables of control and intervention groups were compared using unpaired t-tests for continuous, Fisher exact tests for normal, and Mann-Whitney tests for skewed distributions. To make sure the reduction in the primary outcome measured, so the apnea-hypopnea index, was directly correlated to the exercise interventions prescribed, Pearson correlations were used to establish the significance. So they only allowed values of P of less than 0.05 to be put in the significant bracket. Unfortunately, the integrative style of this study means that oropharyngeal exercises are grouped together, and so the specific exercise or exercises influencing key statistics like the apnea-hypopnea index cannot be signalled out. Finally, the last source I studied was the effect of exercise training on obstructive sleep apnea and sleep quality, a randomised controlled trial. And it is, as it says, an RCT, so it's a level 2 on the NHMRC scale. As the selection process for candidates required that they either had a previous diagnosis of OSAS or had a high-risk classification obtained from the Berlin questionnaire, the possibility obviously exists that some of the study group did not in fact have OSAS. However, as the study measured both primary and secondary outcomes for the condition at baseline and after completion, having a previous diagnosis of OSAS was probably negligible. The intervention and control groups were randomised and both treatments prescribed as active, so as close to blinding as probably possible for a physiotherapy treatment. The objective measures of sleep onset latency, total sleep time, wakefulness after sleep onset, and sleep efficiency were determined by the ability of patients to adhere to the use of the ActiWatches correctly. It also used standardised values of medium threshold to detect waking and used 5 minutes without movement as the beginning of sleep. So for the objective results of this study to be as accurate as possible, the functions of the ActiWatch should have had to be individualised before the study. The statistical power of the results could have been improved from 80% had the two groups, treatment and control, been more evenly spread. So as it was, the study had a 3-to-2 ratio of treatment versus control. There was no set minimal adherence levels required to maintain enrolment in the study, meaning obviously some people may have not been doing all their exercises at home. T-tests were used to both compare the differences between individuals' baseline values and also between their attendances. So by using previous standard definitions of success and response to treatment, which is greater than 50% of an AHI reduce from baseline, and a greater than 20% reduction respectively, the legitimacy and usability of these results attained is definitely improved. McKinnon's product of coefficients test and linear regression models were used to rule out other possible mediator factors that could have influenced the change in OSAS severity. So things like BMI, falling body fat percentage, and respiratory muscle strength that could have affected the AHI drop. In summary, as an intervention, the use of both aerobic exercise and resistance training to lessen the severity of OSAS is still in its infant stages. So for fair studies to be undertaken, exercise needs to be the only intervention applied to the patients. So this means forfeiting CPAP for the duration of the test. So for this reason, amongst others, that sample sizes for the studies to date are either really small or they test combined interventions. So for example, exercise and diet or exercise and CPAP. Exercise intervention is also something that is extremely difficult to blind patients during. However, the statistical significance of the results in all the three sources propose a promising first-line treatment without having to adhere to CPAP usage. Along with primary and secondary outcomes of OSAS being significantly improved, so that is the AHI, sleep efficiency, snoring, daytime sleepiness, the results were also found to exist independently to BMI changes. So that is to say that BMI was not directly affecting the reduction in AHI and the other primary outcomes. It raises the same queries though that we're seeing with the CPAP, and that is that the level of patient acceptance and adherence in programs greater than 12 weeks and unsupervised is yet to be studied and proven. So my next recommendation, probably for the study of OSAS intervention, exercise intervention, will be longer term studies, obviously, bigger cohorts, and testing each exercise independently, just so you can get a gauge for what is the most effective treatment. However, with no apparent negative side effects on the exercise programs implemented, so specifically on overweight and obese individuals, I'd have no problem implementing them in combination with, at first, or as a standalone treatment in patients of mild to moderate OSAS, so either with CPAP or without. patient willingness, and adherence allowing. So that concludes my speech on OSAS. Thank you for listening today.